Hello and welcome everyone to today's webinar. If you could please in the chat let us know where you are tuning in from. I am broadcasting from Columbia, Maryland, TMA's office. I'm Rachel Bromley, TMA Senior Manager of Patient Education, Support, and Advocacy. And it turns out our chat is off, so sorry about that. We will get that working for the next webinar. And so we are here today, and I am excited to be here. Give me 1 second. I'm going to share my slides, and then we will get started. All right, thank you everybody for coming in. Before we get started, disclaimer, TMA does not give medical advice. Our educational webinars are informational, and we encourage you to make all decisions in your partnership with your healthcare team. We are very grateful for our expert speakers from all over the world. We ask each speaker to disclose any potential conflicts at the start of the presentation. Just so you know, this webinar is being recorded and will be available on TMA's YouTube channel as soon as possible. Please input your questions into Q&A. Questions in the chat may be missed. Pre-submitted questions are being loaded into the Q&A by staff. TMA evaluates its programming to make sure we are meeting the needs of the community. So a survey will pop up at the end of the meeting. If you would please fill out that survey, we would appreciate it. So again, today's webinar, Understanding IVIG and Myositis Care, Insights from Clinical Practice and Research. TMA, since 1993, we have been working towards improving the lives of persons affected by myositis, funding innovative research, and increasing myositis awareness and advocacy. Our vision is a world without myositis. We'd like to give a special thank you to our sponsor for this webinar, Octapharma. Thank you so much. And before we get to Dr. Gandiga, we have a special guest. Kelly Jo Bell is a patient with dermatomyositis and currently undergoing IVIG, and it is my pleasure to introduce her. All right, Kelly, how are you doing today?
I'm doing very well. It's nice to be here and to be among friends.
Well, great. Well, tell us a little bit about your journey.
Well, we all have our own journeys, right? Some are very similar and some are very different. I'm just going to tell you about mine. I consider myself a autoimmune nightmare. I have obviously dermatomyositis, I have Sjogren's, I have Raynaud's, I have you just name it. You get one and they all just keep coming. So I started off, I was in and out of the hospital for about 16 weeks when my boys were in high school. They couldn't figure out what was wrong. I was so fatigued. I mean, more fatigued than the word can describe. And they finally sent me to Cleveland Clinic. And at Cleveland Clinic, they came back with I had thyroiditis, Addison's disease, and congestive heart failure. So here, let's do steroids for the Addison's, and of course, this levothyroxine, etc., for the thyroid, and then the heart failure meds. So I was on that, came back to Kentucky, was seeing my endocrinologist. She was following the recommendations. And after about 4 years, I told her, I'm just really done with this. I kind of need a break. I'm feeling good. I don't think that I need the support anymore, the steroids. And so she cautiously took me off, and I remained off of them for, I want to say, 4 years, right around then anyway. Then I had a very traumatic year. I lost all three of my grandparents. I lost my sister, my brother, my two best friends, and my roommate, all within 8 months.
Oh, no.
And to add insult to injury, this little girl thought she needed to run a 10K. Well, I'd been running 5Ks, and I mean, I averaged 15 to 20 miles a week. Knowing now, I was running, literally running from my problems, the things I was having. So after the 10K, I got a rash and I was so sore. So I go to my primary care, who I'd been seeing for 15 years or longer. And she said, "Oh, I'm sure this is hives because it was just on my chest." And she said, "Let's do a steroid dose pack." She said, "With all the trauma you've had this year," she said, "I'm sure it's nerves." And I said, "Yeah." And I'm sore. And she said, "We're getting old, ain't we?" And so it was kind of okay. So I go back after that steroid dose pack was over, and I'd be off of it for a week. The rash would come back, and the muscle pain and the fatigue. So we did that song and dance for too long, but it's only because she knows me so well that she felt safe doing that. And she was keeping such a close eye on me. Well, I got to where I could hardly move. And my son had come down and he runs marathons. And he said, "Mom, that's not right." He said, "Something else is going on. That's not right." He said, "You need to go back to the doctor." I said, "Okay." So, I mean, it got bad. My girlfriend had just had a baby. And so she would walk down to my apartment and I would hold her baby and she'd pull us in the wagon down to the pool because I couldn't walk that far. I couldn't walk more than probably 5 yards. And I mean, it wasn't just that, it was, I could not move. I felt like I was walking in drying concrete, that it was sticking to me. And each day I was getting worse and worse and worse. And the rash was just terrible. I mean, I looked like I had blisters. Then it went across my shoulders, on my back, across my face, in my scalp. And so one night after being down at the pool, I was feeling disgusted. And so I was laying in bed and I said, "God, I can't do this anymore. I'm done. I cannot do this. I cannot. I give up." And he said to me, "No, girl, you wash your face. Wash your face and get down to business." So I did. I got out my iPad and I'm a researcher. And so I'm plugging in all these symptoms and everything. And the only thing I could think of was that I had muscular dystrophy or muscular sclerosis. Those were the only two muscular diseases that would come to my mind. And I'm a nurse, maybe a little pretend nurse, but still. So, I felt like, okay, this is it. So I called Jane and I could hardly get the words out. And I said, "I think I have MS or muscular dystrophy." And she said, "No." And her heart sank, my heart sank, and I was in tears. And I said, "Yeah, I do." And she said, "That doesn't explain the rash." You're right, it doesn't. Add rash, up comes dermatomyositis. And I'm like, "What the crap?" So I wrote it down, called my doctor, and I told her nurse, "I know what I have." And she said, "Well, come on." And so I went over like in 15 minutes. The doctor came in, I handed it to her, and I said, "This is what I have." And she said, "What is that?" I said, "I don't know, Kim, but it's what I have." And she said, "You're so excited." I said, "It just means there's hope." Then she said, "Okay." And so she looks it up, grabs me by the wrist, takes me upstairs to the dermatologist. And he took one look at me and he said, "You know what you have?" I said, "I do." I said, "Would you tell me how to say it?" And he told me, and he said, "I'm going to be completely honest with you." He said, "The only reason I know about this is because I had to do one of my papers on a very rare disease." He said, "And this was the one I chose. I've never seen anybody with it. I've never treated anybody. I will work with your rheumatologist." And he said, "And this is who you're going to." So I made an appointment. I go in. She says, I don't know what to do about this. I've never treated anybody with it. And I said, well, that's just dandy. What are we going to do? And she said, you want to learn together? I said, yep. It's my next appointment. I brought my iPad. She sat in the chair next to me, and I'd already found out about TMA at that point. And so I'm Googling and I'm telling her, look at this. And she'd pull it up on hers. And she joined a site for physicians. So she was learning about it. So we now knew what it was. Now, how do we treat it? Well, so we do all the usual suspects. Go back on the steroids. Let's do Cellcept. Let's do, oh my gosh, what else did we do? Methotrexate. We did them all. And I was getting worse. I lost my hair completely. I mean, I went completely bald. I lost down to 97 pounds. People didn't even recognize me. The scalp rash was, you'd think it itched when you say rash, it hurts, it burned. And every time I could touch my bald head with my cold hands, it felt good. So the muscle weakness was, I was just getting sicker and sicker. The steroids were helping, but they weren't giving me anything that I needed. So I go in one day and I said, um, I saw this study on TMA. And she said, okay. And I said, it already started. I said, but they are talking about this stuff. Um, it's a proderm study. And she said, a what? And so she's Googling it and she says, well, okay, but it's already started. I said, I don't care. And she said, what? Do you want to try it or something? I said, I'm going to die if I don't. And she said, no, no, no. She said, you're not going to die from the dermatomyositis. She said, but you probably are going to die from a complication. She said, anything that's a muscle can be affected. So my heart dropped again. So I go home and I call my insurance company. I talked to them. I did a peer to peer, went through everything. And I told them I want to try this Octagam. And they gave me an approval. So I started on the Octagam from Octapharma, and I was sending my doctor a picture every 30 days because I only saw her every 3 months. I doing the same thing with my dermatologist, and I saw my dermatologist at month 8, and he said, "How are you feeling?" And I said, "I just really don't feel good." And when people be nice to me, I kind of break down a little bit. And so I was trying to hold myself strong, and he gave me a hug and he said, would you please give it to month 10? He said, just don't go off of it yet. He said, you have been so deathly sick. He said, it's going to take a little bit. I said, okay. Well, I'm here to tell you the next month, at month 9, I felt better. It was like I got up one day and the heavens opened, music played. I thought, oh my God. I said, I hurt, but I feel so much better. I just feel so much better. Still gives me chilly bumps when I think about it. I was not having to sit on the floor to put my makeup on because I was having to bring my head to my hands because I couldn't raise my arms above my head to dry my hair or do my makeup. I didn't have to crawl on the floor to my bed to stand up anymore. I was able to walk from my bedroom to the kitchen and carry a cup of coffee with just one hand instead of two. All these little things that you think, oh, they're big things when you can't do them. And so I just continued on that road. And every day, even still, every day I feel better. When I was getting the infusions at the hospital because I was so sick, the nurses were surprised when I'd come every month because they didn't expect me to. They didn't think I was going to live the next 30 days because I do my infusions day 28 and 29 of every month. And they were surprised. They started meeting me down at the door with the wheelchair. And I said, I ain't doing that. I said, I'm walking in here. when I can't walk in here anymore, just be done with me. And I mean, we went out for margaritas a couple of weeks ago. I mean, my life turned around. I am no longer afraid of dying from DM. I'm no longer afraid of dying from a complication of DM because I have learned my body on such a deep, deep level. I mean, it's like I can tell the minute something is off. And it's because DM raised my awareness so much. My hands were cracked and bleeding. Um, I lost my voice completely for, I think, 9 months. I couldn't talk above a whisper. Um, I was bald 3 times. My hair had come back, and I think, all right, listen, it came back completely silver. It came back bright orange. I looked like Fozzie Bear. It stood straight up. I mean, we're talking. My eyebrows have not come back. They're microbladed on. Um, the easiest part of dermatomyositis is when I was bald because I didn't have to fix my hair. My eyebrows were microbladed and I just stuck on false eyelashes and I called it a day. I'd wear a beanie. So I tried making everybody feel comfortable around me by wearing a wig. And where my scalp was so inflamed, it
Mhm.
hurt. Wigs hurt.
Yeah.
And one day I was talking to one of my patients and she said, "Oh, Cal," she said, "that's a great wig on you. That looks so good." And I turned my head to say something to somebody else and my wig stayed. And I was like, "Ah." So I pulled it off and her eyes got about this big. And I said, "Why am I wearing this?" And she goes, "Oh, it makes you so beautiful." I said, "I'm wearing this to make you comfortable." I said, "That's stupid." I said,
Meanwhile, you're
"I'm
uncomfortable.
I'm making myself uncomfortable to make you comfortable." And I never wore them again. I wore beanies. Spring came, my hair was starting to come back in, still had some pretty good bald spots. Sat outside on a Saturday. On Monday, the doc I worked with came in and I gave him a slug in the arm and he said, "What's that for?" And I said, "You've got to tell me sun blocked my head." He's like, "Oh, yeah." He said, "Us bald people have to wear sunblock." So, I mean, it's been very, very challenging. It's been very, very humbling. I have never, one time, only one time in my life have I asked for help from somebody, and it was from my mother, and she told me no, and I will never ask for help from anybody again. What I have is a circle of friends, a tribe that knows when I need something, and they come running. Like I
That's
couldn't run my vacuum sweeper. And so my
awesome.
girlfriend bought me a Roomba. I mean, the
Well,
little things you can't do. So
absolutely. And thank you so much for sharing your testimony and putting a human face on this. I know a lot of people in our audience know exactly what you're going through because they are going through it themselves or they
absolutely,
have gone through it. And so we do so much appreciate you being here. Thank you for, again, sharing your testimony. And we are looking forward to moving on now to our speaker. But before that, I am going to launch a poll. So one moment while I launch this poll. Okay, it should have popped up on your screen. How long did it take for you to receive your dermatomyositis diagnosis? 1 to 6 months, 6 months to a year, 1 to 2 years, or more than 2 years. We have about 30% of the audience has participated. As soon as a few more people have answered, I will end the poll and share the results. Okay. You should see the results now. We have 45% of the people that answered were diagnosed in under 6 months. Between 6 months to a year was 21%. More than 2 years is 18%, and 13% is between 1 to 2 years, and we have 3% at other. So that is good information to know. And now I'm going to stop sharing my slides, and Dr. Gandiga will come on and introduce himself and start sharing some of his expertise. Welcome, Dr. Gandiga. How are you doing?
Hi, thanks so much for having me. For all of you guys, thank you for joining us this evening. I'm Prateek. I'm a rheumatologist. I work here in Atlanta, Georgia, where I run the Emory University Myositis Clinic. So really appreciate the chance to talk to all of you guys this evening. Really want to take a pause to give Kelly Jo a really big round of applause and thank you for sharing your testimony and your story. Hopefully it resonated with a lot of you. I know it resonated a lot with me. I think that, even the poll shows that, we as a community have made a lot of strides towards advancing myositis and dermatomyositis care, but obviously we still have a really long way to go. And that's one of the reasons that I love working with this community and trying to help people that have myositis, and educate other people, including doctors and other medical professionals. So I'm glad to have the chance to talk to all of you guys this evening, to try and share some ideas and some thoughts so that you can have some of these conversations with your care team and your family members as well. Just as a matter of disclosure, I am involved in myositis research and myositis education. I don't have any relevant conflicts in the information presented to you guys today, but I do prescribe some of these treatments that we talk about, including Octagam, in my routine clinical practice for some of my patients. And so, part of the thing that really resonates with me when I talk to people like Kelly Jo and when I talk to patients is how individual everyone's story is. And that's one of the really hard parts about dermatomyositis is it's really an individual disease. I teach the residents that even if you have three people that have exactly the same antibody subtype or exactly the same subtype of myositis, they really have three different stories. And that makes it really hard in a couple of ways because we really have to think about treating people in a tailored fashion. And that also makes it hard because it really has to be a conversation between a patient and their doctors and patient and their other family members to try and figure out, all right, how are we going to tackle this together? So I really, really appreciate TMA and Octafarmer for giving us the chance this evening because one of the sets of questions I get a lot of questions about is about IVIG therapy and Octagam therapy. And so the idea for tonight was to try and give you guys some information and some background so that you can be educated and that way you can be an active participant when you have those discussions. And so we thought that we'd talk a little bit in terms of when I'm seeing a patient as a myositis specialist, what are my goals when I'm talking to people and when people are talking to me about treating their DM? What are some general strategies that we think about when we're kind of trying to approach these? And, IVIG, like I said, I got a lot of questions about it. And how does that actually fit into those goals? And then we're going to do a little bit of a mini deep dive to give you some of the data and some of the background. There's no quiz, so you guys can take notes if you want to. But we really want to look in terms of Octagam and, why was it specifically FDA approved to treat DM? Because I think that that's really a huge milestone in our field, both from a science point of view as well as from a clinical point of view. And so just kind of diving right into it, what are the goals when treating DM? Well, I don't think I need to tell all of you guys that dermatomyositis is really a disease that has a profound impact on patients. And dermatomyositis originally was kind of thought to be just one thing, but over the last 5, 10 years especially, we've realized that it's really a family of systemic autoimmune disease. What do I mean by systemic? Well, it can affect multiple organs. And so we talk a lot about dermatomyositis affecting the skin and causing rashes, or sometimes affecting the muscles and causing muscle inflammation and weakness, but it can also cause joint inflammation, or in some patients, you can get autoimmune interstitial lung disease, and that feeling of feeling unwell that Kelly Jo talked about, and kind of feeling like you just have that malaise and fatigue, sometimes even affecting those muscles of swelling like the pharyngeal muscles. And not every patient experiences every symptom. And so, like we said, it's a really individual type of a story. One of the big things that we've had are these myositis specific autoantibodies, and they're specific in the sense that we see them in myositis. We don't see them in other autoimmune diseases. And maybe they help give us some clues in trying to help further subdivide the family of disorders, make predictions about patients and what kind of things we need to be on the lookout for, what types of treatments might be helpful for them. But, from that standpoint, from a 10,000-foot view, what are the goals when we're seeing anybody that has dermatomyositis? And what do we really need to think about? Well, so, when I'm thinking about a patient and I'm talking to them, I really want to know how is their particular dermatomyositis affecting them? Because the treatment that we choose is partially based on the type and the intensity of the symptoms for a particular patient. So, do they have really bad rashes and skin involvement? Do they have really bad muscle involvement? And then we also need to think about not just medications, but also those non-medication interventions, like that physical therapy and that reconditioning, and really kind of looking at somebody in a 360-degree view. And there are two main kind of phases of treatment when I think about it. So sometimes I think about it and I use the analogy of a building on fire. So if you're thinking about a building on fire, my first job is to say, all right, I want to try and get this fire as small as possible quickly because I want to try and prevent it from spreading to other areas. I want to try and prevent and limit the amount of long-term damage there could be. And so that induction treatment is kind of the analogy we borrow from our colleagues that are oncologists. And then once that fire is under better control, well, I want to prevent it from kind of flaring back up. And these two kind of things are just kind of a thought process, and people switch back and forth, and you may have flares or things like that. But that's really kind of when we're thinking about the treatment, and that fits into how we're choosing the treatments. Unfortunately, it's really hard because the optimal treatment really is unclear, and there's only a few medications that have formal FDA approval for dermatomyositis. A lot of the things we use are because of historical reasons that we end up using them, or we happen to have them around, and that's why we used them in the past. So, all right. So now that we know a little bit about, at least as a physician, what I'm seeing when I'm seeing patients and what patients are asking me when we're trying to get our goals, well, what are the general strategies in terms of how we actually end up picking medications and thinking about them? And in general, there are two or three big classes of medications we think about. The most famous by far, I'm sure, are glucocorticoids or steroids or corticosteroids, and so those are things like prednisone, Medrol, Solumedrol. I'm guessing that a lot of you guys have been on that either currently or in the past. And steroids are great for a lot of reasons. They're great because they're kind of a big broadsword sledgehammer. They affect the immune system in a lot of different ways. And so oftentimes we'll use them because they end up acting pretty quickly and they try to help us with trying to control the symptoms pretty quickly. They're also my least favorite kind of medication for exactly that same reason. Being such a broad medication, they can have a lot of side effects, and especially if we're using them in the long term. And so this will include things like infection risk, high blood pressure, high blood sugars, weight gain. We have limited studies in terms of how exactly we end up using it, but one of the big themes that a lot of us that are in the myositis field are how can we limit exposure to glucocorticoids, especially in the long term, and use them really just kind of on a spot treatment until we can get someone onto something that's a little bit more focused. What does more focus mean? Well, that really kind of depends on the person. And there are a lot of different drugs that we end up using, and some of them are called traditional DMARDs. Those are things you may have heard of, like methotrexate or mycophenolate or azathioprine. And we've used them for other autoimmune diseases, and we've brought them into myositis because we know those medications really well. There are other options that we've been working on in terms of developing specifically for myositis, but also we end up borrowing medications that were originally designed for things like rheumatoid arthritis or lupus, thinking that maybe the pathophysiology, the way that they work, may also help with dermatomyositis. And typically, for the most part, these medications have a better long-term side effect risk than glucocorticoids, but that side effect risk is really kind of dependent on the particular one we're talking about. And oftentimes you end up having to worry about, all right, what are we doing for toxicity monitoring? Do we have to do blood testing? Do we have to do these other things? Unfortunately, one of the big things that we're lacking is kind of trying to say, all right, I'm sitting down with you and knowing what medication is going to be the best choice for you and which you're going to tolerate and respond to the best. And that's really kind of difficult, especially when we come to some of these more targeted medications. Well, what about immunoglobulin, including IVIG? How does that fit into that? Well, in a way that's actually kind of helpful, and I put it in a separate category for a reason. So, immunoglobulin is actually made from human antibodies that are collected from donated plasma. So, you guys may know that we all have these immunoglobulins, these antibodies that your body makes that are part of its immune system and help protect us against infections. And what we can do is we can take donated plasma, separate it out into its different parts, include good in collecting some of these immunoglobulins and then purify that and give that back in terms of helping with certain autoimmune diseases. And that's helpful because this has actually been well studied in dermatomyositis, and I'll show you some of that data a little bit more. That for the most part, that big study, the prodrome study that we'll talk about, showed us that most of the side effects from this are mild and temporary, and then there are certain situations in which it seems like it's really helpful to have patients be able to use the IVIG. Unfortunately, it's hard because typically with intravenous administration, you have to be either at an infusion center or sometimes at a home nurse. There have been some smaller studies looking at could we use subcutaneous immunoglobulin. That's not as well established, especially in dermatomyositis. And they can be costly, although this is typically covered by insurance. And I'm so glad that Kelly Jo was able to kind of talk with her insurance and get that to be covered. Things have gotten a lot easier now that Octagam is officially FDA approved as an IVIG formulation for dermatomyositis, but it still can be a little bit difficult. So I am always curious because I think that this is one of the things that we need to work on. Can you guys tell me a little bit about what types of treatment have you tried to manage your DM or have you heard about or talked about? And so, Rachel, would you mind bringing up that poll?
Everyone should be able to see it now. Okay, we have answers coming in. About half of the audience has participated, so we will wait just another minute.
Tease you guys. Usually, when I'm giving lectures to the med students, we have chocolates for people that answer questions, but we don't have them for you tonight. But but that
Right.
said, you guys should still weigh in. I mean, this is the way that we learn, is to be an active participant.
Okay, I'm sharing results, so you can go over those.
So that makes a lot of sense. So a lot of you guys have said, yes, I've seen steroids, and that makes sense. Traditionally, they're one of the medicines that we had, back in the day. And so, they've kind of just ended up infiltrating all parts of life when we end up treating people with autoimmune diseases. But I'm really glad to see that a lot of you guys are using non-steroid immunosuppressants, and actually that a lot of you guys are heard of or seen immunoglobulin in terms of your treatment pathways and things of that nature. We didn't ask about those non-medication treatments, and that's a really important type of a thing. But this gives me a little bit of background so that way we can kind of say, all right, let's kind of put this into context. And I'm going to focus a little bit more on the immunoglobulin and IVIG because it does seem like about half of you guys have seen that and may want to end up being able to educate others or talk with your physician team about that. So, like I said, all of us have these antibodies floating around. When people donate blood, well, we can separate that blood into separate parts. And so, in IG therapy and immunoglobulin therapy, we start with healthy donors that end up donating their plasma, and we separate that into parts and actually isolate the immunoglobulin there. We end up pooling together a bunch of people that have donated things. So, usually for each batch of IVIG, it's about 10,000 to 100,000 people's immunoglobulins that get pulled together. And that gives us a really broad range of specificities when we end up thinking about those antibodies from a science standpoint. And then that immunoglobulin separated out, it ends up getting purified. They end up making sure that there's no viral infections or things of that nature. In terms of the purification process, the differences between these different immunoglobulins has to do a little bit with the purification processes that each manufacturer employs, has a little bit to do with the kind of buffers and things like that that they end up using. And then that purified immunoglobulin is mostly a class called IgG, and that's given as a medication for dermatomyositis. And so again, the dosing really depends on the person and their weight, how they're given, whether it's given at home or in an institution or in an infusion center. Again, those are all kind of logistic questions that end up coming into play. So how does IVIG work? And that's a great question. And I'm laughing because, I wish that I could tell you exactly how it is. One of my very good friends, Yasmin Ventura at University of Chicago, likes to think of it almost like a decathlete, where IVIG does a lot of different things. And we think that a lot of those different things interact with the ways that dermatomyositis affects the body and actually affects it in a lot of different ways from that standpoint. And so we think that there's a couple of different things that it can do that are helpful for both autoimmune disease in general, but dermatomyositis in specific, including neutralization of some of these autoantibodies that we think are really important for the disease propagating. So one important distinction between IVIG and some of these other medications we talked about, including the steroids and the non-steroids, is that we think of IVIG as an immune modulatory effect rather than an immune suppressive effect. So what do I mean by that? Well, immune suppressive effect is actually blunting the body's ability to interact with infections or fight infections and things like that. Immune modulatory is the way of regulating things. So sometimes I think about almost like a kindergarten. If you have a bunch of unruly kids in the kindergarten, well, an immune suppressive effect is sort of like going in and taking some of those unruly kids out of the room. But an immune modulatory effect is like going in and having a teacher's aide in there and making sure everyone's calmed down so that you still have the immune function that you need, but it seems like things are playing better with each other. And so it seems like this is really important because, that's really unique amongst the therapies we typically use with dermatomyositis. And so from that standpoint, that's really kind of one of the reasons that we think about it in its own separate category. And sometimes I think about immunoglobulin therapy as a backbone, meaning that, when I'm thinking about people and I'm saying, all right, what's the one that's going to do the heavy lifting? Who is the agent that I'm going to rely on the most? Sometimes I'll use the immunoglobulin that way, especially in some of those induction phases or things like that. Sometimes I use it as an add-on where I'm saying that somebody else is going to do the heavy lifting, but I need something to let me get the last 10 yards and really help this person out. And again, the situation depends on the person, the situation depends on the goals of therapy and how they're doing. There are a couple of special situations where we really want to think about IVIG as clinicians, and that's because it seems like there's data to support the use of IVIG in those situations, especially. And one of those includes people that have really aggressive, severe dermatomyositis. So some of you guys were saying that it took about 6 months or so for your disease to end up getting diagnosed. Other people, 2 years. I've had some patients where, it's been really hard to diagnose them because they've had such mild disease that's been persistent and impacting their quality of life, but thankfully hasn't been causing their CKs to go really high or having them to have a lot of weakness. I've had other patients where, I have one young girl, unfortunately, she was an NCAA basketball scholarship, went from that to really kind of not being able to do much over the course of 3 months. And so in patients that have that really severe aggressive type of a disease, oftentimes I'm thinking about IVIG either as an add-on or a backbone medication right up front. Patients that have a high risk of infection or have active infections, like we talked about, IVIG doesn't seem like it increases your risk of infection, and so it's really helpful in that situation. Pharyngeal muscles are kind of some of these upper muscles that are involved in swallowing, and so sometimes in some patients, those muscles can get affected, just like the other muscles that get affected in dermatomyositis. And there is some data and some studies that are out there that show that IVIG may be particularly helpful in that situation. And then, with a little bit of a caveat, patients who are pregnant. So there's limited information in terms of using IVIG in pregnancy, but for the most part, it's considered to be a safe treatment to end up using. And that's really helpful for me if I do have a patient that's pregnant, because I'm really trying to limit the toxicity both to the mom and to the child at that time. And so in those situations, kind of really important to talk about IVIG with the care team that's involved. What to expect with IVIG infusions. So, traditionally the infusions are given roughly every 4 weeks or so. Usually we take the total dose and we split it into 2 to 5 smaller doses that are usually given on consecutive days. As we mentioned, those are typically administered at an infusion center, or sometimes we can do it at home under a nurse's supervision. The infusion typically lasts several hours, depending on the infusion rates, and we'll talk a little bit more about infusion rates in a second. Octapharma was kind enough to give us some videos. If you guys would like to watch those, you can scan the QR code and be able to link to that to kind of get a little bit more of an idea about that in case you're not familiar with those things. Okay, so so far we have a little bit of an idea in terms of when I'm seeing a patient, what are my goals of therapy that I'm going to talk about with the patient and the general treatment strategies I'm going to talk about. Now, so this is the part where we're going to do a little bit more of a deep dive into IVIG and really kind of focus a little bit more on Octagam because that's where we get the best data for using IVIG in dermatomyositis patients. So who first thought of doing IVIG? It had been used really spottily in the past, but really, Dr. Delikas and his team were the ones that really put IVIG on the map as a potential treatment option for us. And this was back in 1993. And they did a really small study. They ended up having 15 patients total, with the crossovers only about 10, or I'm sorry, only about 12 of them ended up getting immunoglobulin. But this was really important because at that point in time, we really didn't have a lot to offer patients with dermatomyositis. And this was an exciting new type of a treatment that maybe there was another option. But, it was kind of really hard because this is a really small study. And so this is a pilot, and in a pilot, you have really limited data on how well IVIG works. You really don't know about how safe it is. There's a lot of unanswered questions about, how quickly it acts, how long it lasts for, wasn't FDA approved, so that means that it's really hard to get for patients, even if you wanted to end up trying it. So sometimes the analogy I'll use is sort of like, going to a restaurant and having that recommendation from one of your friends, and your friends being like, oh man, that place is amazing and whatnots. And then you go there and it turns out to be a terrible meal, and the friend swears by it. And you're like, okay, this is kind of a really different experience. The more people that tell me that this is going to be really helpful, and the more people that can tell me about the details of the service and how the meal was and things like that, the more and more likely I am to trust that. And so, from that standpoint, it's really important to actually end up doing robust science to actually kind of look into this and kind of see what's there. Despite those lacks, the Delica's paper was really the biggest support that we had for IVIG for almost 30 years until Rohit Agrawal and some of the other colleagues in the trial ended up doing this large multi-center placebo-controlled trial. And this was really a landmark for a field in a couple of ways. At the time and even now, this is one of the biggest studies ever done in dermatomyositis, and it really ended up doing a lot of robust work in showing how well IVIG and Octagam, which was the medication chosen for the study, works. It used these well-established tools, including this thing called the Total Improvement Score, which had been well studied and well thought out. So we know objectively that's a good way of kind of looking at some of these responses. They collected a lot of safety data and a total of 40 weeks of follow-up, which lets us know about how quickly it works and how long it works for. And this honestly led directly to the FDA approval of Octagam, which is the medication that was used in this study, as an effective and safe treatment for dermatomyositis. So, do you guys want to see some of the weeds and kind of see some of the data? Okay. So you guys can read the paper on your own if you'd like to, and it's always fun to read some of the papers and kind of know where we get our information from. But I'm going to highlight one of the key figures for you, and I'll walk you through this. So in this figure, if you look, there's two areas. One is light gray and one is dark gray. In that light gray area, that's what's called the randomized phase. So in that randomized phase, everybody ended up getting some background medications, including things like methotrexate, nasothiabrin, and stuff like that. And about half of those guys ended up getting placebo, and half of those guys ended up getting IVIG. And then they were periodically, every 4 weeks, coming in for evaluations and doing some of these formal testing, doing this thing called the total improvement score. And to calculate a total improvement score, you're looking at a couple of different things. You're looking at some objective measures of strength on physical exam. You're looking at muscle enzymes. You're looking at all of the non-muscle manifestations of the dermatomyositis. You're asking patients how they feel through a formal, well-validated survey, including things like the hacks and whatnots. And so we know that the total improvement score actually correlates not just to what we're seeing in clinic, but also to how patients are feeling. And we think that a total improvement score of somewhere in the neighborhood of about 30 or so is clinically meaningful for patients, meaning that if you have a total improvement score greater than 30, it means that you're going to end up doing better, feeling better, having better improvement in your activities of daily living. So in that randomized phase, there are a couple of things that are really important. You can see even after a single dose, if we look at the average total improvement score, the people that got the IVIG actually started doing a little bit better than the people that got placebo. And that effect seemed like it kept going and building on itself all the way out to that week 16. And then when you followed them in that darker gray section, that's open label. Open label means that everybody knows whether they're getting placebo or IVIG. And that's really important from a science standpoint. They have that blinded phase so that you're not biased. But even in that open label phase, it looks like, that benefit of IVIG continued to be there. It didn't end up wearing off or things like that when people were getting treated with it up to that 40-week mark. What's even more cool is that if you look at that blue line, the placebo patients, well, at week 16, they ended up getting open label infusions of IVIG. And you can see people actually started improving once they got the IVIG. And that's really helpful for us as well, because we know it's not just random chance, it's good science that you actually are seeing that it's the IVIG that's driving that benefit and not just the background medication or things like that. And so this really kind of gives us robust information on how well Octagam worked for these patients. And a lot of these people were having not just benefit, but clinically significant benefit that was improving their quality of life. And so, based on this, the FDA looked at the data and said, okay, we are going to approve Octagam as a safe and effective treatment for dermatomyositis. And in fact, this is the only recent FDA approved treatment for dermatomyositis that we have as of today. The part of the reason for that is if we look at that total improvement score, there are three thresholds that we end up using. One is a total improvement score of greater than 20, which we call a minimal response. The moderate response is that greater than 40, and the major response, which is greater than 60. And we think that, making sure that patients have at least a minimal response, but more likely a moderate response is really important. And you can see that in the Proderm study at that week 16, all of those categories, minimal, major, and moderate, actually looked better in the patients that were getting Octagam versus the patients that were getting placebo. More importantly, or just as importantly, I should say, no patients that were getting the Octagam had clinical deterioration, meaning that they were worsening and had to get rescue. But in the placebo group, about 6% of those patients ended up needing something else because their DM was flaring or acting up on them. Just like I said, it's really important to get safety data and say, all right, what's the other side of the equation? Thankfully, when we look at the safety data, most of the side effects that were reported were mild in intensity. Far and away, the most common was a headache. That's in about half of the patients, and people can have some infusion reactions, including fevers or nausea or chills. But for the most part, those were pretty mild in intensity and pretty self-limited. Thankfully, no increase in infections with the Octagam, which, thankfully supports what we would think of. And the risk of serious events was very low. And so from that standpoint, it looks like there are ways to kind of limit those serious effects. So what kind of side effects were we thinking about? One of the biggest ones was this concern in terms of, well, we knew for a while in other places IVIG could be considered to be associated with blood clots and thrombosis. And so with the Octagam study, we ended up saying that number one, that rate was pretty low, but then the safety group ended up reducing the maximum rate of infusion to 0.04 milliliters per kilogram per minute, in case you're interested. But if they follow that cap and how fast you give the Octagam infusion, then it ended up dropping the thrombosis rate to somewhere in the neighborhood of 0.53 per 100 patient years. What does that translate to? That translates to roughly less than a 1% chance of that thrombosis type of thing occurring. And so other studies have shown that if you slow the rate of infusion, also decreases the rate of headaches and things of that nature. And so from that standpoint, that's kind of one of the reasons that people complain about how come I have to be getting the IVIG over such a long period of time. And that's one of the reasons that we end up dosing it and giving it the way that we end up giving it. Okay, so I am curious because I think that I asked the same question at one of our state rheumatology societies and things like that, and we're still trying to spread the word about effective treatments for dermatomyositis, and I'm getting more and more questions about IVIG. So I'm curious as to any of you guys have heard about Octagam and in which venue that you ended up getting about it.
While we're waiting for folks to answer this particular question, do you mind sharing? We had a couple questions come into the Q&A, and we're going to go over and answer as many as we can. But one came up, does IVIG help other forms of myositis? Is there any way to use it for IBM, necrotizing?
That's a great question. And so what I'm going to say is that it's hard because we don't have a big study like we did with the Prodrome study looking at Octagam. We do have smaller studies and we do have other data, and then we also have case reports and clinical experience and things like that. So there are big gaps in our knowledge in terms of, all right, what percentage does it end up helping out with, et cetera. Some of those things are being studied as we speak or in the process of getting studied as we speak. We do think that IVIG helps with lots of different types of myositis, including immune-mediated necrotizing myositis, which most people think is a subtype of polymyositis, including things like antisynthetase syndrome or things like that. Thank you for asking the question about inclusion body myositis or IBM, because I know that IBM, well, I'll say all types of myositis are frustrating. It's frustrating to patients and it's frustrating to physicians because we don't want our patients to have to deal with it. I think IBM is one of the most frustrating because as the patients dealing with IBM know and their family members know and their clinicians know, we really haven't found a lot of stuff that's been shown to be effective and safe in reducing IBM symptoms and progression. When you look at IVIG and IBM, part of the reason it's hard to study is the nature of IBM and the fact that IBM tends to end up taking a long time for people to end up having that progression of disease. It's not typically as aggressive as things like PM or DM. In IBM, there have been case series and case reports of people saying that IVIG seemed like it helped their patients with IBM. But again, using that restaurant analogy, all right, well, can we study this a little bit more robustly and see does that really bear up in scrutiny? And so in some of those studies that were done, and they were relatively small, unfortunately, they weren't really able to show a benefit of the IVIG and IBM. And so, from that standpoint, you always, as a scientist, are kind of saying, all right, is this because the medication doesn't work well, or is it because it's working in a way that we're not able to capture, etc.? So there have been some studies or some other things that have some flaws, but at the same time maybe have some interest where maybe IVIG can slow down the rate of progression of IBM, even if people progress despite getting the IVIG, or maybe it improves their functionality or their other symptoms. I think it's really a unclear area. In our practice, if people ask, or if I'm talking to a patient that has IBM and we talk about IVIG, I'm pretty straightforward in terms of talking to them about the lack of information and what the information is, and kind of have that shared decision making, because there are some situations where patients have felt like, let's see if we can try and get IVIG approved and see how much of a difference it makes. But you do also have to understand that IVIG is a medication, just like any other medication. There are downsides to trying it as well. And so I do think that that needs to be a really individual conversation between physician, their patient, family members, etc. Okay. So I'm gonna pause there, and I promise you that we will definitely
Did
have
you
time
want
for
to go over the results of the poll?
Exactly.
Great.
So I was going to end up saying I'm going to pause the questions there. I promise you we'll definitely talk more about some of those questions. And it does seem like, a chunk of people have heard of Octagam. And, I'm glad to hear that a chunk of people have heard about it because of their healthcare provider. But I think that, part of the reason I wanted to ask the question is because this means that, even as a myositis aficionado, in our field, this is a huge landmark study that everybody knows about, and it seems like we're not doing a great job of spreading the word. And so I think that that's one of the reasons we wanted to end up doing the webinar tonight, is to make sure that you guys have the information to both have that conversation with your physicians, but also to do us the favor of trying to make sure that we're educating and we're advocating and helping our community by spreading the word about things like Octagam and IVIG therapy. Okay. So, moving on a little bit, one of the questions that comes up a lot is the cost of Octagam and other types of treatment. Thankfully, because of the FDA approval, it's gotten a lot easier to get the insurance companies to pay for it. Easier is not easy necessarily, and sometimes those copays are pretty significant and whatnots. I was really grateful to find out that Pharma has actually started a copay assistance program. And so, from that standpoint, hopefully that'll help us get more patients that would benefit from Octagam to be able to access that, even if the copays were otherwise cost prohibitive. Um, in terms of kind of closing remarks, so I think that, Kelly Jo can attest to this, all of you guys can attest to this, that living with dermatomyositis is really challenging. It's hard. It's a hard disease. It affects a lot of parts of your life. And I think that it's hard because, like I said, it's a very individual disease. But I think that, the ways that we as a community and as we as patients and providers can fight against this is being educated, being involved, being active, making sure that we're kind of keeping in mind not just the medication side of things, but also the non-medication side of things, the physical activity, the limiting things when you're tired, and acknowledging how frustrating this is, and really coming together as a community and realizing that, we're all in it together. And so, from that standpoint, I really appreciate all of you guys joining us today because that shows a commitment to both yourselves and those around you. So, if you only listen to one thing this entire evening, I think that the biggest evening take home message that I really would like to share with all of you is really talking. And talking is really important. And that means that it's an active conversation, and that it's a conversation that means that you can help educate your physicians can help educate you. And there is, unfortunately, no one right choice for any particular person, but there is choices, and kind of trying to pick amongst those to try and help make the best decisions with the information we have. So with that, I will end up giving some information. If you guys are interested, or if your physicians are interested in kind of deep diving into some of the information about Octagam, thankfully being FDA approved, your tax dollars at work, the FDA does do a monograph that really kind of summarizes a lot of this information, especially for dermatomyositis, and it kind of gives some uh, brief glance in terms of the information about what types of things to look out for. And just as importantly, in my mind, it kind of really shows in terms of what are the rates of potential side effects. Because knowing that something could happen doesn't mean that it will happen. And it's nice to know how often it does happen. And so I'd encourage any physician that's on the call this evening, or patients that are interested, to look into this a little bit further. I'm going to pause there. I know that I spent a little bit longer than I was expecting. But Rachel, if we have time, I'm happy to hang around. I think Kelly Jo said that she was free as well, and so we could kind of answer some more questions if people are around and available.
Okay, we have about half a dozen, no, not half a dozen. We have 2 dozen questions in Q&A, and we're going to try to get to as many of them as we can. Should immunosuppressant medicine be co-administered with IVIG?
That's a great question. And so I think that that goes back to that slide that I had ended up putting up, in terms of putting IVIG in its own category and talking about whether it's going to be a backbone medication or whether it's going to be an add-on medication. And so I would say that the short answer is it really depends on the situation. There are a lot of patients, and in fact, probably the majority of my patients that are on Octagam or other IVIG formulations right now are getting it in combination with another medication. Sometimes it's methotrexate or azathioprine or mycophenolate. Sometimes it's other medications as well. And so I think that it really ends up depending on the situation. There are some papers and there are some patients where using a single treatment with IVIG like Octagam has been enough to control their disease. And so in that situation, the patient and their physician team has decided that that's going to be their sole medication and monotherapy, and be able to control the disease that way. So again, it's a really individual type of a situation, but I don't think that there's anything quote unquote wrong with mixing immunosuppressant medications along with Octagam octagam. And in fact, that's the way that it was actually done in the prodrome study.
So this is possibly also depending on independent variables, but we've been asked, how long should a person stay on IVIG infusions? Do you have any general guidance?
That's a great question as well. And so I think that, one of the reasons that it's such a landmark study for us is that the prodrome study gives us some information about that to actually make some rational decisions and discussions. So, in the prodrome study, if you remember that graph, they ended up having some benefit after that first infusion, but then that benefit on average ended up stacking on itself and seemed like it ended up going all the way out to that 40 weeks. And so it does depend on the individual situation. But I would say that based off of the Prodrome study, most of us that use Octagam in our routine practice for patients will typically end up having patients on it for at least 3 to 6 months before we start making decisions, assuming that people are tolerating the medication well and there's not another reason that we end up having to stop it. And that particularly goes for patients where I'm using it for that initial induction, where I'm trying to get the disease quiet and keep it quiet as long as possible. Again, it's individual, and like you said, it has to be a discussion. But that's kind of the general type of a way that most people think about it.
Would there be any benefit to receiving IVIG if you've never had it and the disease is stable on immunosuppressant and low dose prednisone?
That's a great question as well. And so I think that, one of the key points to that question is that last sentence, low dose prednisone, and how do we think about prednisone? So for the longest time in rheumatology, steroids were all we had. And, frankly, there was a time where we didn't even have glucocorticoids or prednisone or things like that. I think that from that standpoint, historically, that's really kind of made prednisone have a place in rheumatology that it probably deserves, and to a certain extent, it probably doesn't deserve. I think that, a lot of us, especially people that have trained previously, have gotten into the habit of just leaving people on steroids indefinitely and, not thinking about the long-term consequence. Like Kelly Jo said, previously people were saying, all right, well, you're going to die in 6 months. What do I care? And I think that, that's really a way of thinking about it that's a little bit outdated. There are definitely patients that are out there that need to be on some dose of prednisone, and that's a joint decision between them and their physician. But in a lot of cases, I will be talking with the patient and saying, okay, what kind of things can we do to try and get rid of the prednisone? And is the side effect risk of adding something like, IVIG or Octagam going to be worthwhile? In some cases, the answer for that is yes. And I think that in those situations, especially with the safety data that we end up having, I would pick something like that over long-term, even low-dose prednisone if I had my druthers. But, again, it depends on the situation.
How often do patients suffer blood clots from IVIG therapy? And once this has happened, is it necessary to rule out that therapy?
No, so if you end up looking at some of the information that we have, that risk of blood clots overall, unless somebody has a underlying history of clotting or things like that, seems like it's pretty low. So it's, like I said, 0.53 per 100 patient years probably translates clinically into about a less than 1% chance for a patient to end up having that blood clot issue. If people do develop blood clots, it really kind of, again, depends on the situation. So there are patients that end up having blood clots on IVIG, and you're always kind of wondering, with that particular situation, was it because or related to the IVIG? Was it related to something else? Sometimes there's what's called provoked clotting. So, like for instance, if someone ends up having a blood clot after a knee replacement, then oftentimes we say, all right, that makes sense because of the way that knee replacements work and things of that nature. So in certain situations, I think that, again, off-label use, because we really don't have a lot of information about what to do if someone has a thrombosis or things like that. I think that there are certain situations in which we would want to not use IVIG or pause using the immunoglobulin for at least a period of time, and kind of reassess. There are other situations where we would say, all right, maybe it's safe to continue using it, especially if somebody is on blood thinners or things like that. So it sounds like it's a lot of variables that come into play and a lot of discussion that needs to happen with the physicians.
How is the effectiveness of IVIG therapy assessed over time, and what is the time frame typical to determine if it's working? Like we see today with Kelly Joe, it was the 9th month, not the 8th month, but the 9th month. Is that a typical average, or does that vary also?
That's a great question. So you remember those curves that I showed you? Those curves are averages. And so that's really important because averages mean that some people are going to be above that, some people are going to be below that. And so it's really kind of an assessment that needs to be done every time that you end up seeing your physician. So every time I see one of my patients with dermatomyositis, I'm going to end up talking to them because I think talking is really important. You're going to get a sense in terms of how they're doing in their daily activities, how they're doing in terms of some of those things that are hard to measure, like their fatigue, looking out for kind of some of these other areas that may not have been involved in the past, but are now involved, and kind of getting a sense from them in terms of how they feel like things are improving. The physical exams also really, really important. And so, kind of looking at their strength, looking at their skin, looking at their lungs and their heart and things like that. And sometimes those labs come into place. So that total improvement score, that TIS score that I talked about, that's a more formal way of assessing some of those things. But even if people aren't sitting there and calculating a TIS score in their office, which, to be honest with you, when I'm not seeing somebody in a clinical trial, I don't bother doing that. But all of those components are kind of going into my mind in terms of that gestalt of how is somebody doing. And I want to see how are they doing now compared to where they were 6 months ago, where were they 3 months ago, where were they a month ago, and kind of really seeing what the trajectory has been. It's really hard because I think that if you had somebody that was getting IVIG for, say, I'm going to arbitrarily pick like 3 or 4 months and really not noticing much of a benefit on that, from that standpoint, we would kind of think about, all right, do we need to change the situation of the story? And sometimes that might be continuing the IVIG and the same regimen and giving it a little bit more time. Sometimes that might be continuing the IVIG and changing other parts of the regimen and seeing if that makes a difference. Sometimes it may be stopping the IVIG and trying something else. So I think that, from that standpoint, the hardest part of dermatomyositis is kind of that Goldilocks zone where sometimes it's frustrating for both patients and physicians that you have to be a little bit patient and wait for things to kind of end up improving because some of these things lag behind. But at the same time, you don't want to be complacent and give it too long before you end up saying, all right, we need to switch and we really need to do something different.
Do you think sub-Q is a better option than IVIG long term? And for those in the audience who do not know what sub-Q is, if you could explain the difference.
Rachel, you're asking all the hard questions tonight.
I'm
Um,
not. It's our very well-educated audience. It's not
Well,
me. I'm just
I'm very
reading.
impressed. I mean, this really shows a lot of active engagement and a lot of education, and this is one of the reasons I love the myositis community so much. So subcutaneous. So if you think about your skin ends up having that kind of top layer, and then underneath that top layer, you have a fatty layer. So subcutaneous means that you're giving a medication with a needle that's long enough to go below that really top layer, but not long enough to go into those deepest layers. And so it's under the skin, subcutaneous. And so with immunoglobulin, there are some formulations of immunoglobulin that are subcutaneous in and of itself. And one of the reasons for that is I love IVIG because we use it for dermatomyositis and we use it for myositis and things of that nature. But IVIG is also used for other type things and not just autoimmune disease. One of those is there are certain immunodeficiency diseases where people can't make enough of their own immunoglobulin. There are other diseases where the immune system's attacking nerves or things of that nature. And so in those situations, sometimes they do use subcutaneous immunoglobulin, especially for CVID, where people can't make enough of their own immunoglobulin. One of the big problems with that is that when you dose immunoglobulin for those things, you're giving much lower doses than the doses traditionally used for dermatomyositis. So, for instance, for Octagam, the dosing is typically about 2 grams per kilogram of body weight, whereas if you're dosing things for CVID, you're usually dosing about 0.4 grams per kilogram. So it makes it hard because if you're dosing a full dose of immunoglobulin, that's a lot of volume, a lot of liquid that you have to end up putting in. And in the cases where case reports or case series have used that subcutaneous immunoglobulin, they typically end up doing it on like a weekly basis or things like that. There's some technical difficulties with doing infusions and things of that nature. So I think that a lot of us in the field have said that subcutaneous immunoglobulin is a really interesting option. There was a study that was trying to formally look at, can we end up using this in this situation? And unfortunately, it seems like that really didn't pan out for a couple of reasons in the trial itself. But I think that it's not something that's routinely done in clinical practice, at least as it is right now. So from that standpoint, it's kind of a little bit hard for me to advocate for it or against it.
Would you please tell us the difference between IVIG and IgG?
Great question. So IG, big I, little g, stands for immunoglobulin, which is a shorthand way of saying antibodies. And so there are a lot of different flavors of immunoglobulin. They're sort of related to each other. They look a little bit different when you actually look at the cartoons or the way that those things are. They're all proteins, is kind of the short answer, and they're all different proteins. There are a couple of big classes and general classes of Ig antibodies. One is IgG, so big I, little g, big G. One is IgA, one is IgM, and there are other variations thereof and there. So IgG is important in the immune system in a couple of different ways that are different than the ways that IgA and IgM are important. And does it make a big difference from a clinical point of view in terms of knowing that IVIG is mostly IgG and not really IgM? Not necessarily. We do have to, there's this theory that if some people have IgA deficiencies, could they be at more risk of getting a reaction if they're exposed to IgA or formulations that have IgA in it? And, that comes into play. Again, it's kind of pretty uncommon and not really rare, or I'm sorry, not really seen or clinically as relevant. But from the science standpoint, it makes a big difference. From a clinical standpoint slash from a patient standpoint, doesn't necessarily make a huge difference in terms of thinking about these things.
If you are on one product, can you change to another globulin product?
That's a really hard question, and so that's an excellent question. So in terms of the available IG or IVIG formulations that are out there in the US at least, and there's a couple of flavors that people may be familiar with, including GammaGuard and Privigen and Gamunex and things of that nature. So all of the different formulations end up being different because of the way that they're processed, and so each manufacturer has a slightly different way of processing the immunoglobulin once it's been pooled. I'm sorry, once it's been actually collected and pooled and purified. All of them have slight differences in the buffering and things like that. And so, traditionally we've thought about them as kind of maybe they're six of one, half dozen the other, but it's really hard to say that for sure. Ultimately, and for better or for worse, IVIG with Octagam is the only one that was actually formally studied and looked at. And so, if people end up saying, can you tell me in terms of what are the side effects of IVIG? I can tell you that not necessarily. I can tell you in the prodrome study what were the side effects that we saw with Octagam, or if you ask me what is the efficacy rates of IVIG, I can tell you I don't really know. I know what the efficacy rates of Octagam are, and that's part of the reason that the FDA approved Octagam. Does it make sense that it probably is the same for the other ones? That's again hard to say, but at the same time, ultimately sometimes we have to argue with the insurance companies to end up, getting Octagam approved, and sometimes they'll make us try one of these other agents instead.
When you are on IVIG, what blood work should be monitored and how often?
That's a great question. So IVIG, for the most part, doesn't typically affect things like blood counts, liver counts, like other medications such as methotrexate might. And so, if we're talking about, just like any of the other medications, you can have certain situations in which you do have a rare side effect with IVIG, including things like hemolysis, breaking up red blood cells, or things like that. Thankfully, those side effects are really, really, really uncommon. And so they're not things that we typically routinely monitor for. And so, unlike some of the other medications that I would use, like methotrexate, I don't necessarily have to get labs routinely to monitor for IVIG toxicity. The flip side of that is in my patients, even those that are doing well, I typically do want to get labs periodically to look at their disease activity and their dermatomyositis. The labs aren't the only thing that we take into account, but they are a data point. And so I do oftentimes want to end up getting blood work done. And how often that is depends on what other medications they're on, and if I need to monitor toxicity for that depends on how their dermatomyositis is doing. So I do have some patients that are on IVIG, and they've been doing fantastic. We haven't been able to get rid of the IVIG or Octagam or whatever formulation we're using. And so from that standpoint, they've been on it, for a year, 2 years or more. And again, this is off label. But from that standpoint, I may see some of them every 4 to 6 months, and I'm usually checking labs around that point in time as part of my assessment for the disease activity. But the take home message, I guess, is that as far as the IVIG is concerned, typically we don't routinely monitor labs for IVIG toxicity per se.
We have time for one more question, and that is, how do you taper IVIG use if you decide to come off of it? What are your suggestions?
That's a great question as well. And so this is also an area where there's not a lot of information. And so I will say that straight and foremost. So we end up having quote unquote expert opinion and kind of practice. And part of that is talking in amongst other people that treat a lot of patients with dermatomyositis. So for the most part, I can speak to my clinical practice and how I usually do it. And again, it's an individual situation. It depends on the physician, it depends on the patient and the situation. So, take this with a huge grain of salt and know that it's something beyond the scope of what we have data for, including the Proderm trial. Um, from that standpoint, typically for most of the patients with that I have on IVIG, unless there's a reason that I can't continue it, I usually don't stop it cold turkey, and I usually end up tapering it down. Typically, what I'll end up doing is tapering it down by roughly 10 to 20% of the dose, and then kind of waiting a little while, seeing how someone's doing, and then if they're continuing to do well, then continuing to taper it from that standpoint. Sometimes there are situations where either logistics or the patient's preference or other factors come into play, and we do have to stop it, kind of a little bit more abruptly. And thankfully, it's not a medication in which there's a rebound effect in terms of the actual medication itself. But in those situations, part of the reason for tapering it down rather than stopping it cold turkey is so that I can keep a sense of what their dermatomyositis disease activity is like, and do I need to make adjustments to the other part of the medication and non-medication regimen for the patient? So, you need to be extra vigilant if you're doing that when you're stopping things cold turkey rather than kind of tapering it down, because you may not have as much time to react to those changes.
Well, thank you so much for being here today. And thank you also, Kelly Jo, again for sharing your story earlier. And we are just, everybody here in the audience and in the myositis community appreciate everything you both do in your respective areas for other people living with this disease. So thank you. I have a few announcements.
Okay, and I'm going to thank like all of the people that stayed here, especially those that were able to stick around a little bit longer for the Q&A. I was always taught that the first part of things is showing up, and showing up means that you're actively engaged and you're not just a passive participant. And I really appreciate that, and I really really appreciate the advocacy work that TMA does in terms of sharing information, and I think that we're all in it together. And so, thanks to the sponsors for taking the time to actually say this is worthwhile, and let's try and make sure that, I'm glad that at least 25% of the patients had heard about Octapharma and Octagam, but 25% means that we got a long way to go. So I really hope that we'll be able to take the information that we talked about today and kind of use that and apply that and spread that word.
Absolutely. Kelly, did you want to share a few closing remarks?
The only thing I would like to say is before my brother passed, I asked him if there was anything I could do for him. And he said yes. He said, I need you to smile through it. And through the it has been everything. And I think if we can keep a positive attitude and to know that we're not in this by ourselves, though it feels like it at times that nobody understands, if you can look in the mirror tonight and know that you made somebody's day a little bit better, God lets you get up tomorrow. And that's what it's all about, to smile through it and just be there for each other. I couldn't make it
Absolutely.
without Octapharma and TMA. I wouldn't be here.
Well, thank you so much.
Thank you for
All
having me.
right, everyone, I've got a few announcements and then I will close for the evening. Don't miss our upcoming events. We've got Myositis Research Insights webinar with Dr. Will Fong on Thursday, December 4th, and then an Ask the Expert Speech Language Pathology edition with Dr. Garand on December 11th. So we would love to see you there.
If I can make a plug, I know both of them very well. They're both excellent clinicians, they're excellent speakers, so definitely would encourage people to come.
Well, thank you so much. I will be sure to tell them that also. TMA new member orientation open to all. Doesn't matter how long you have been with TMA, but it's a great time to see what's all available. And that next one will be Friday, January 16th. And of course, all of this is available. You can register on myositis.org on our events calendar. And also we're coming up to end of year giving, and there is Giving Tuesday on December 2nd. And so if you're led to provide any support, feel free to do that on our website. And we actually have this cool tech organizer that's labeled that can be sent to you for a donation. So I had to put that plug in there. Anyway, thank you all for coming, and enjoy the rest of your day, whatever you have left.
Thank you all.
Bye
Have a
now.
great evening. Be well.
Bye.